Thank you, Dr. Ramchandani, for your very, very kind words. And you had told people that I have selected this topic. No, I have not selected this topic. This topic was allotted to me by Dr. Bansi Sabu. And may I tell you that it is a topic which I don't know from where I should start and where I should stop. So I will take the cue from Dr. Kanungo that he has described you how to treat adult type 1 diabetic patients. And as we all know that type 1 diabetes is a disease which is usually occurring in a younger age group, and then patients are having, you can say, progressing, their age is advancing, and then they may be having so many different presentation, different behavior. So I think I will be discussing those aspects of a type 2 diabetic patient, how during the lifetime he is having so many different aspects of disease management. So we all know, as Dr. Kanungo highlighted beautifully, that type 1 diabetes is an autoimmune disease. There are so many stages of type 1 diabetes during the development of diabetes, as we all know, stage 1, 2, 3, and then disease is progressing. But as compared to type 2, now the disease has settled very rapidly into its, you can say, full strength. And then insulin is the treatment, but it is a treatment which we all know is requiring so many ifs and buts. So as Dr. Kanungo highlighted, there are so many difficulties in diagnosing this type of patient in the, you can say, adulthood or in the elderly patients. So islet antibodies are helpful. C-peptides are relatively higher in our adult patients. And sometimes these patients are also having obesity because of excess amount of insulin they are using. And we have to differentiate them from type 2 diabetes and sometimes monogenic diabetes also. And we also know that type 1 diabetes also occurs in older people, what we label as a LADA. And there are so many clinical features. And the young onset of diabetes, lower BMI, unintentional weight loss, and ketosis and diabetic ketoacidosis and very high blood glucose profile usually tells us that we are dealing with type 1 diabetes. This is a flow chart what Dr. Kanungo highlighted, that once you are having a difficulty in diagnosing, you have to look into islet antibodies. You have to look at the age of the patient. Then, of course, you will be measuring C-peptide. And then you are looking into the characteristics of monogenic diabetes, which are absent, and characteristics of type 2 diabetes, which are absent. And then we say that these patients are not responding to oral drugs and they require insulin. And that is what we say latent autoimmune diabetes of adult, which is sometime developing after 30 years of age. And the suggested criteria is that they are having age more than 30 years. They have presence of islet antibodies, and they absence of insulin required. Insulin requirement is there after 6 months of diagnosis of this. So they are having slowly progressive beta cell loss, and most of these patients do require insulin, in fact, and we have to differentiate them from type 1 diabetes by age of onset, which is later in LADA. Symptoms of hyperglycemia is relatively milder, and insulin requirement for 6 months, they may be on oral drugs. They have BMI which is better than type 1, and the risk of long-term complication may be lower, and islet antibody titers are usually, you can say, lower in this patient as compared to type 2. So what are the aims and goals of management of these type 1 diabetic patients once they are having, you can say, in adulthood, and you find that LADA is a form of diabetes which is occurring in adults, and they require this type of presentation as we just discussed. And here you can see that blood glucose profile changes according to the stages of life. And here, according to this criteria, you can look at what is that blood glucose profile for toddlers and preschool kids, school kids. And once they are having extensive lifestyle, extensive disease after many years of diabetes, and they do develop complications of diabetes like nephropathy, etc., then of course we want to have less tight control in them. Dr. Kanungo beautifully highlighted this aspect, that these patients require self-monitoring of blood glucose, insulin, risk of hypo and hyperglycemia is to be looked into. But once they are going from the young age in childhood to transition to adulthood, Then age-related responsibilities of these young adults are there. They have living situations which are changing. Now they are going into colleges and they are working now. Age-related changes affecting self-management, preventing, detecting, and treating acute complications are also, you can say, changing, prevent and detecting and treating chronic complications. Now the chronic complications start appearing after many years of type 1 diabetes, and we have to look into that aspect. And sometimes they do develop other autoimmune conditions like thyroid disorders or rarely adrenal disorders. And then they have to go for problem solving of day-to-day activity. And in our female patients, they have to plan their pregnancy also. So in long duration of type 1 diabetes, there are chronic complications they have to deal with it. Then there are so many other comorbid conditions they have to look for, you can say, management of pregnancy. They have to change their diet and physical activity. And now is the time that they indulge in so many other things like smoking, alcohol, and other drugs, and they may be having sleep disorders. And now earlier they were on treatment by their parents. Now they have to look into their own treatment. And sometimes these patients are going for a intensified management. They shift their, you can say, multiple insulin injections to insulin infusion pumps, etc. And regarding their review of monitoring, you find that earlier they were looking into self-monitoring, but now many of them are now using this CGMS systems. One important aspect is once they are growing, you have to look at the growth of these type 2, type 1 diabetic patients, which has to be looked into by measuring their height and looking into their weight and monitoring and charting their you on this growth chart. But important point is, if the child is not growing, probably they are having uncontrolled hyperglycemia, but sometimes uncontrolled, you can say, thyroid disorders, presence of celiac disease, and other comorbidities are also causing, you can say, retarded growth in them. So we have to look into that aspects also. Some of these patients are having delayed puberty. As they grow, they do not achieve. And we have to look into if there is no thelarchy by 13 years or no testicular growth in boys by 14 years, then we have to screen these patients, look at liver function, kidney function, glucose profile, and thyroid functions. And if these are normal, then go for FSH testing, karyotype, autoimmune markers are to be looked into. And then, of course, if all these are okay, then glucose profile is important. Uncontrolled hyperglycemia is also an important cause for delayed puberty. Many of these girls are also having excess of weight gain. They do have excess amount of insulin, and they have PCOS type of presentation, where like hyperandrogenism and ovulation, and on ultrasound we have a clear-cut picture of polycystic ovaries. These patients who are now adult, sometimes they are given adjuvant therapy in the form of metformin, pramlintide, GLP-1 receptor agonist, and SGLT2 inhibitor with insulin. That is important that they do continue with their insulin. And sometimes these drugs are also used in this, you can say, in follow-up of these patients. They go for tighter control. They navigate their route for glucose normalization by either SMBG or insulin pump. And many of them, after many years of disease, opt for islet cell transplantation also. And once they are having complications like chronic kidney disease and they want to go for pancreatic transplantation, you can see they may go for simultaneous pancreatic kidney transplantation or only pancreatic transplantation. And there you can see that how they behave in this. Risk behavior is very, very important in this patient in the later part of their life. Youth with diabetes frequently experiment with diabetes mismanagement through non-adherence. They may also engage in other risk behaviors, including tobacco, alcohol, recreational drugs, and unprotected sexual intercourse. Behaviors can interfere with the diabetes self-management. Females are more likely to participate in diabetes mismanagement, where boys are engaging in risky behavior. Alcohol is also an important problem there. And now they start driving. And that driving is an important concept, because if they develop hypoglycemia, then it will lead to more accidents in these patients. So these are the different behavioral consideration, like change in their nutritional therapy, alcohol, smoking, physical activity, sleep pattern are also influencing their diabetic behavior. Sick day guidelines and illness management are to be looked into. And as I discussed, driving, and now they are having employment or they are traveling a lot. That also is to be looked into their behavior. Psychological problems are now cropping up in these patients. Diabetic distress, diabetic depression, anxiety, and disturbed eating behavior are very common. And anorexia nervosa in type 1 diabetes is not uncommon, particularly in our type 1 diabetic patient. And many of these are also having bulimia nervosa, and there they eat a lot and then they go for self-induced vomiting to reduce the weight, and they sometimes use laxatives, diuretics, enemas, etc. And sometimes they skip their insulin also. So those are important problems in these patients once they are having long-term type 1 diabetes. Social problems are now also coming in. Social and financial hardship can negatively impact the emotional health, motivational and opportunities, and capacity to engage in self-management, and lack of perceived social support. For example, family support is not there. That is an important aspect in these patients. And then, of course, our female patient now want to go for a family side pregnancy, including preconception and postnatal care is also to be required into, and because if they are uncontrolled, then they have poor prognosis of pregnancy outcome. So it is a time where they should be going for a very tight control. As we all know, a HbA1c of less than 6.5, and fasting should be less than 95, and 1 hour should be less than 140, and 2 hour postprandial should be 120 or less. And many times we are also using CGM in these patients. So there are many challenges in these patients regarding pregnancy and during postpartum also. And now the patient is old now. So there are so many diabetic management aspects which are now changing. These adults should be individualized with safety as a key priority, because now they are having all those different complications of long-term diabetes, and glycemic target should be according to the functional status rather than the life expectancy, because many of them are very active, many of them are in a very bad shape. And target glucose is to be given according to their functional capacity. And you have to look into complications of these diabetic patients in elderly, and glycemic targets are to be modified. And we have to look into all those other chronic complications, like these patients developing chronic kidney disease, gastroparesis, and they are having all those problems of retinopathy or acute painful neuropathy. And of course, we have to avoid hypoglycemia in them. And of course, these are the now patients, not only type 2, but type 1 diabetic patients are also having excess amount of cardiovascular disease. They do have significant retinopathy. Diabetic kidney disease is very commonly seen in our long duration of type 1 diabetes. Blood pressure of these patients after many years of type 1 diabetes starts rising. We have to look into that aspect. And lipid is also to be looked into. It is sometimes seen that only lipid lowering drug is required in type 2. No. They are also required in type 1 diabetic patient if you find that their blood lipid profile is deteriorating. Of course, neuropathy and diabetic foot problem after very long duration of type 1 diabetes is another concept in these patients. Here I want to highlight a recent study that there is a reduced expression of OX, FOS, and DNA damage gene, which are linked to protection from the microvascular complications. In this study, which is by the name of prolonged study, chronic hyperglycemia and diabetes duration, we say they go hand in hand. But there are subsets of patients who are not usually developing these long-term complication, vascular complication, in spite of long duration of diabetes. So how to compare those who are having non-progression of complication and those who are having progression? And here they looked into the gene analysis, and they say there is a reduction of expression of oxidative phosphorylation gene and DNA repair enzyme gene, which are less. This is BER, that is base excision repair mechanism, which is reduced. And because of this, they are having a better glucose profile, and there is a decrease in inflammation, and they have better insulin sensitivity and protection from the complication. So this prolonged studies tells us that not all the patients with long duration of diabetes are having chronic vascular complication. Hypoglycemia, Dr. Kanungo beautifully highlighted in our patients with elderly diabetes, type 1 diabetes, long duration of diabetes, old age, history of recurrent hypoglycemia, alcohol, and chronic kidney disease and other comorbid conditions may lead to more hypoglycemia. There is a loss of sympathoadrenal reaction, recurrent hypoglycemia, sleep disturbances, psychological stress, and alcohol is also contributing there. And again, there is a study, recent study, where they looked into GABA, that is gamma aminobutyric acid, which was found to exert an immunomodulatory effect on these beta cells. And in this study, they have given slow release GABA preparation, and they looked into what happens to this outcome of this counter-regulatory mechanism. And they say that once these patients are on GABA, there is a better, less chances of hypoglycemia, and they have some improvement in their beta cell function also. And the last aspect of my talk is life expectancy of type 1 diabetes is significantly reduced. And we all know that they have something like 20 years of decrease in their life expectancy. But in Europe and in USA, many of these type 1 diabetes are living more than 40 years. And in golden year cohort, they were living for more than 50 years. So is long-term diabetic survival is there in Indian context? And here we have a study by Dr. V. Mohan, where he looked into this long-term survivors and non-survivors. And he says that large number of his patients were even achieving a long life in spite of long duration of type 1 diabetes. And when he compared survivors to non-survivors, those who are having better glycemic control, good blood pressure control, and favorable lipid profile and lower prevalence of complications are having better survival as compared to those who are not surviving, you can say those who are not surviving to 40 years or so. So these are the causes of death in these patients. Ischemic heart disease and renal failure is the most common. And you can see as the years are advancing, survival curves are telling us that within a period of 5 years, 20% of them are dead. In 10 years, about 40% are dead. And in 20 years, about 60% of them are dead. So as we are giving better control of hyperglycemia management and other aspects, more and more of our type 1 diabetic patients are now surviving. And recently in JAPI, this is a study mortality pattern of type 1 diabetic patient in West Bengal by Dr. Debashis Maji and all. And they say they looked into 22 years of follow-up of their type 1 diabetic patients. And here they looked into what is the cause of how many of them are living more than 20 years and what is the cause. And CKD was the most important cause, followed by coronary artery disease and DKA. So thank you, dear friends, for looking into this long-term aspects of type 1 diabetes in our, you can say, care. Thank you very much.